focuses on how social, structural, and cultural factors influence HIV transmission. And by using rigorous formative research, she can develop culturally appropriate interventions to kind of address these factors. So she received a BS in psychology from Fordham University, a master in public health from Hunter College, and a doctorate in health education from Columbia University Teachers College. And at the moment, Dr. Bond teaches as an assistant medical professor in the Department of Community Health and Social Medicine at the CUNY School of Medicine.
Okay, I guess this is when I take over, right? I just want to thank you for the introduction and also welcome everybody again to the Physicians for Human Rights at the CUNY School of Medicine's COVID-19 vaccine, putting it into the pandemic panel discussion. Again, everyone, my name is Keosha Bond and I'll be your moderator for tonight's panel discussion. And just to go over to kind of support some of the objectives that we mentioned before. The goal for tonight's discussion is to really address some of the inequities related to vaccine distribution to underserved communities in New York, and to learn more about what our city is doing to provide vaccines to individuals within the underrepresented communities. And so before we get started, what I'm going to do, because I don't think you want to hear a lot from me, and I think you probably want to hear more from our panelists, I'm going to ask our panelists to introduce themselves and kind of give them the audience a little bit of background, who they are, and their role within addressing the COVID-19 pandemic. And so we're going to start out with Dr. Alan Roth. If he could just introduce himself and kind of talk a little bit about what he's been doing during this time addressing the pandemic.
Can you hear me?
Yes, we can.
So I am a practicing family physician in clinical and academic medicine. I've been practicing family medicine for many years. Like I said, I'm probably the oldest one here. I've unfortunately spent the last year and 3 months of my life treating COVID, evaluating COVID, creating COVID programs for both COVID care, COVID prevention, COVID treatment, COVID testing, as well as the COVID vaccination. I ran a COVID unit at Jamaica Hospital for 4 months during the peak of the pandemic. And the last year or so of my life has been taking care of both COVID patients with long hauler COVID syndrome, as well as being the lead on Jamaica Hospital's COVID vaccination program. As I said, this is the only job I've had in my life. So I've been at Jamaica for 34 years and been practicing in one of their faculty practices in Kew Gardens for the same amount of time. So that's who I am. And I think I'm pretty aware of what's going on with COVID, unfortunately. So I'll be happy to share all of that with you.
Thank you for joining us today.
Thank you for
And
inviting me.
next slide, please. Mr. Jaime Guttierez, could you please tell us a little bit more about yourself and your role within addressing the COVID-19 pandemic at this time in the city?
Yeah, absolutely. Good afternoon, everyone, or it's probably evening at this point. My name is Jaime Guttierez. I work with the New York City Health Department. I take on many different roles. Let me shut my other computer up real quick. Okay. I take on several roles during public health emergencies. For this past one, I started with the Community Partnership Engagement Unit, which is the one that's assigned to letting everyone in the outer boroughs know that this thing is coming, essentially, and here are the best. Here's the best that we know at this time, and that work really started in February and March of 2020. We then later spent some effort building a community advisory board to help inform the way that test and trace would come together and kind of deliver its services, and which later led to the possibility of funding 42 organizations to do test and trace um, kind of public health work in the 25 neighborhoods that were hit the hardest in New York City. And then now I serve as a liaison officer, which essentially means that I am the primary point of contact for any other city agency looking to get an answer from the health department, which is, believe it or not, the easiest part of this whole experience. Did I miss something, Keosha?
No, I think you covered it all. You've been doing a lot in this past year and a half. So thank you again for your service. Next, we will have Blake Fountain. Could you please just introduce yourself and just tell us a little bit about your role with addressing the pandemic within this city?
Sure. So in the chat, I hashtagged Georgia. So I came to New York 2009, I think. I was started out in molecular infectious epidemiology and came here to work on community and health disparities and social behavioral determinants of health as a professor at a pharmacy school in Harlem. Recently, I've been working on the COVID response as the T2 CBO community engagement deputy lead. And really what that means is it's kind of my business to be in everyone else's business. So I meet with, plan, and help organize with NYCHA, the T2 campaign team, who's a group of paid canvassers. I work with the T2 testing team, both their mobile and self-testing groups. More recently, the Vaccine Command Center, especially through utilizing our CBO connections in communities to get those folks vaccinated, and of course my team, and I help to kind of manage that grant work.
Thank you so much, Mr. Fountain. And next we have Angela Soto. Ms. Soto, could you please just introduce yourself to the panel, to the audience, the attendees, and just tell us a bit about your role with addressing COVID-19 in New York City.
Hi, everyone. How are you? My name is Angela Soto. I've been with the agency for a little over 10 years, mainly with the Bureau of STI and then the Bureau of HIV. And in this COVID response, similar to Jaime, from the very beginning, been either delivering community presentations or on the ground with the very first initiation of the rapid testing in the most underserved and most impacted communities in Tremont, Bronx, and then Sunset Park, and then segued right over into flu vaccine access when we were having the fear of a possible twindemic, and then right over into COVID vaccination. My role specifically has been with community engagement. So working with CBOs to see or identify areas of need around COVID vaccine or flu vaccine as it's coming up, and then engaging those partners the best way we can in assuring that the populations they serve are getting either the information that they need about COVID testing, about the virus, or about the vaccine, and reducing misinformation and encouraging or building confidence around the vaccine. So that's my role. Thanks. Happy to be here. Thank you for this opportunity too.
Thank you for being here. And I just want to point out that we are both alumni of the same Masters of Public Health program. And so that I know that you bring a lot of expertise to the Department of Health because of that. So,
thank you.
Next slide. So this part of our agenda, we're going to address some of the questions that the group had came up with that they felt would actually really pinpoint some of the concerns that we felt as a community, not just our CSUM community, but our larger communities that we belong to within New York City. And so this question may necessarily probably gears towards the people who are working with the Department of Health, our panelists. What are some of some barriers that the New York City Department of Health noticed in regards to providing COVID-19 vaccines to the underserved communities?
I can take a stab at it, and then maybe my colleagues and peers can further share. Certainly from the very beginning, even prior to the COVID vaccine, but even having the rapid testing in the most underserved, language as one of the greatest barriers, and not having, even in a diversity like this, not having the adequate representation of in-person translation or interpretation services, one of the greatest barriers that I've seen to date. The other, certainly with the COVID vaccine, and we are all aware of this, are the barriers to getting access to the vaccine. Initially, of course, we had kind of three major, on a more macro level, access to a vaccine that was not there. So the number of vaccines that we really should have had for the New York City were not available. So then we had to create a tiered distribution process. The distribution of the vaccine, which included also just the production of the vaccine in and of itself, and then how we were delivering the vaccine to our various communities, particularly the most impacted when we had such a limited access to the vaccine. In that context, language barrier again, but also access to a vaccine appointment because of the limitations to the internet, even among our adult or older adult population that perhaps did not have language barriers, but now had technological barriers. And I can go on, but I don't want to take all the airspace. So I'll stop there and leave it to everyone else.
Yeah, I can add to what Angela is saying. So, I mean, some of the other things that we saw just on the ground level, doing the field work as early as we did, and there was already chatter and whispers with regards to how fast everything happened, which had a lot to do with the distrust of the federal government, right? The questions were really like, how can we trust that this pill that you're saying, or this vaccine that you're saying is for us, is going to help us, given kind of the legacies that do exist in America around structural racism and racism. And, you know, and then the other part of that, which I think would have done a whole lot to help at least counter those initial messages, was the lack of a real federal plan, a real communications plan on how to really speak about this. And so you find other municipalities speaking about the rollout in different ways, and people, as I always say, are very resourceful people, and they find information. And so it becomes more and more important as we have more public health emergencies to have the same, to have similar messaging across communities.
Yeah. Sorry.
No, you could continue. Don't worry.
Well, in the beginning, I know when I hear this question, I'm like, okay, well, what point in time are you talking about? Because it's a moving target, and I think everyone else can probably relate that in the beginning, access, right, and distribution of the vaccine was a huge thing. We had the mayor who I can't remember if it was Throg's Neck or where it was, but essentially a pod was opened, and instead of in a high equity need neighborhood, and instead of the people there getting the vaccine, you had people from Westchester or White Plains or from New Jersey coming to get vaccinated. So then at that point, it was mentioned within the Department of Health, hey, why don't we get CBOs to tap into their communities and get people to these vaccine hub or pods? And so that kind of took care of that issue. Same thing happened in NYCHA around the same period. There were NYCHA hubs, and they started to circulate I think it was an Airtable link to sign up people within the NYCHA developments. And within like minutes, someone had leaked the leaked the air table, and it filled up with people that were not even NYCHA community residents. And I think something that's plagued us continually is consistency in not only the messaging, but the rollout. Things change so fast that you're in a place where you don't know if, I mean, you're trying to get everyone the information as quickly as possible, but the hubs are changing, the vaccination pods are changing, locations, hours are changing, everything's changing. And when it goes to the community members, they don't understand that process. So I'd say that trust is a huge issue, or has become one as well.
So I'd like to chime in if I could,
Yes,
Dr.
you
Bond.
can. Yes, of
So
course.
first I'll say that, I don't represent Jamaica Hospital Medical Center nor the New York City Department of Health. Though I do work for Jamaica. I do work for Jamaica. I don't work for the Department of Health, but I actually trained 2 of their leaders in this whole project. So Dr. Torian Easterling is one of my graduates. He's the first Chief Equity Officer for the New York City Department of Health. And Dr. Bindi Crouch is another graduate of my program who is actually in charge of the COVID vaccination. So I have had hours of conversations with both of them in the past 14 or 15 months or so of COVID. So I'm not going to speak for them nor Jamaica, but I'll speak for myself and what I saw. But this thing was a disaster that was equally a disaster as the COVID epidemic. We weren't prepared. We weren't prepared for PPE. We weren't prepared for the volume. We weren't prepared for the inequity of who got sick. So we know that people in underserved communities got sick more often, more frequently, and had less access to testing, medical care, and now at this end, less access to vaccination until now. And certainly in the last week or two, everything has changed because now the time is to reach out to try and push people to get vaccinated, because early on, people were scared to get vaccinated, and whether that was right or wrong is a 2-hour discussion as well. But now the problem is there is no shortage of vaccination, but there is turning into a shortage of people who want to get it right now. So people could walk into sites and get a vaccine, including here at the vaccination clinic I work at Jamaica. So there's been a lot of change in the last 2 or 3 weeks.
Definitely. And thank you everyone for responding to that question. From what I've heard so far, some of the challenges that you had to face was uh, one, addressing some of the language barriers that we have, and also creating new forms of access and dealing with the digital divide within our community, and also responding to this emergency, basically the constant changes and addressing the issues of a city that's already been complicated for many years. But and lastly, I think one of the other issues that came up was building trust with the people of New York City and how you're able to do that. So our next question really falls into a line like, what have you, how is the Department of Health working to overcome some of these barriers that you mentioned? From the language barriers to addressing the digital divide with trying to get more people vaccinated, and being responsive to the changes in our community, as well as building trust. Like, what are some of the things that you've been doing and have done to actually address some of these things? And I don't expect your answers to be like the golden rule. I just, just want to know like what efforts have been made. So don't feel that you have to have the perfect answer.
Yeah, yeah. I think I can. I'll start, Dr. Roth. You had 2 comments that I wouldn't want to get unanswered, or at least unreflected, and that's the fact that as a city and as a state, and as a country, there was no plan, and we had to worry about protecting the healthcare workers, and had to at many points make decisions about whether we would run out of the PPE necessary to keep the people taking care of patients alive. And that is, that is definitely a shortcoming of this response. There were many assumptions were made. This was new in large ways to all of us. We've planned and planned and planned and planned in the past, but then plans seem to not go the way they are, even as often as you have iterations of the same plan. And to your point about the inequities that were kind of exposed, so to speak, because I don't think it's an exposure so much as well, this is the same storyline happening all over again. You've been disinvesting in these communities and in these neighborhoods, and of course they're going to be the ones that are going to feel it more, right? So there's those two kind of items that I wanted to just address, not really answer so much because I don't disagree in any way with what you're saying. I'm just a note that it has been felt in the health department. You have two really great alumni, by the way. I like them both. And then to get to the question that you're starting to ask now, Keosha, maybe for Blake and Angela that are on the call, I can start with kind of the idea of mapping that we used in the health department. So one of the ways that we started using whatever the technology we had at the time was our ability to map the areas where we were seeing lower testing and with higher rates of positivity, meaning the people that were going to get tested were testing at a rate much higher than the rest of the city. But overall, the COVID testing was low in that area. Those neighborhoods were able to there were teams of people that were able to get deployed to those neighborhoods to start reaching out to those organizations and influential leaders of those neighborhoods to try to get those testing numbers up, or at least discuss the importance of testing. And I know something very similar was done with the mapping of areas with the lowest vaccination rates. But I don't know if Angela, you'd like to speak a little more about that. But throughout this whole kind of venture of trying to get the data and find it in a timely fashion, there have been some very good efforts made by different task forces. And then when we're talking about government, we're talking about committees and task forces getting stuff done, right? One of them was the tree, and Angela, can you help me out with what that acronym is? I don't know if you're there.
You caught me. I think it's the Task Force for Race and Ethnicity Inclusion. I forget which acronym, which of the letters come first, but basically it's identifying what you just mentioned. It's all of the 33 neighborhoods that either given the with high COVID-19 transmission and low uptake of the vaccine. I don't know, Jaime, if that's what.
Yeah. Thank you. No, and I know, and so just I don't want to suck up all the oxygen on the room either. So I'm gonna give maybe Blake, if you want to give some time to speak, or I can go a little bit into how kind of locally at the Harlem level we've been able to address some of these assumptions that people are making.
I can just give a brief kind of high-level overview of how we address needs. So the grant overall brought on CBOs that work in various communities, specific communities, right? So not only were they based on zip codes with traditional background or a background of disinvestment and under service, but we also had more specific CBOs for each group of community members. So Black and Brown communities, Asian Pacific Islander, LGBTQI. We have NYCHA communities, immigrant communities that we're working with, youth, people over 65. I'm just reading from, I have this huge spreadsheet that I just kind of go with that maps everything that we address. So we have the community members that are experts in their communities. And every week we have, well, the grant has priority zip codes, but every week we recalibrate where it is that we need to focus based on things like low vaccination rate, high positivity testing rates, NYCHA developments that are where that data is coming in that's specific to the NYCHA developments. And then I think, yeah, I think that's kind of like a high level example. I could keep going, and that's part of the trick here, is knowing when to stop talking.
I'd like to chime in a little bit on some of the other ways that we've reduced some of the barriers, but I do want to go back to something that Dr. Roth mentioned, and I think that it warrants highlighting. And I'll begin by just saying that in terms of just the distribution, I think it's important to note that that the allocation really happened at the federal level, right? So then it goes to the federal level in terms of the vaccines, and this is important to note because I'm going to segue right over into an ideal situation in a vaccine delivery system versus what we saw with the COVID-19 vaccine. So I'll begin by saying the federal government determined the allocation for the entire United States, then gave that to New York State or any state. It could be any state, but in this case, New York State. And then New York State determined the allocation for New York City. It never, until very recently, paired or was a 1-to-1, like here's a vaccine for every person that lives in New York City. So given that distribution or allocation, coupled with many times, as we saw even a month ago, when there was a snowstorm in the South, which is the access point to the entire vaccine distribution, the impact that it had, right? The domino effect that it had also impacted how quickly we could actually get that vaccine into people's arms. Now, having that structure in place and then juxtaposing that with an ideal system, right, an ideal infrastructure or vaccination distribution to something that we're seeing now with COVID-19. And I'll use this comparison in having like a flu vaccination distribution system compared to a COVID-19 distribution system. It's an infrastructure we know, right? We have access points, pharmacies, medical providers. We don't need mass vaccination sites for a flu vaccine, but it's an infrastructure that we know versus a COVID-19 infrastructure that we didn't have in place for many reasons, most of it primarily due because we didn't have an allocation that allowed us to distribute this vaccine like the way we're seeing it now. Given all of that, I think that is a huge barrier that we had to overcome, and slowly we're getting there, which now leads to the opportunity to now make, even in a space where I'm at right now at the Queens Center Mall, one of the ways to greatly reduce the barriers and access to this vaccine is to have walk-ins. And that is something that we're seeing here. I don't think even today, we had almost 200 walk-ins by comparison to 88 people that actually booked an appointment. And we've seen that consistently since we opened up at the center, right? But we're only able to do that when we have the adequate amount of vaccine available to us. And of course, there are many, trust, I don't want to undermine trust, but a lot of the trust is also just having people walk into a facility and ask somebody like you and I, or some of the medical providers that are on site, questions about the vaccine. And knowing that tomorrow they can do the same and walk in without an appointment if they really were ready to get the vaccine. And there are many, many issues. I don't want to undermine the historical racism that has also impeded many of our communities from getting access to just basic medical care, let alone a vaccine that we don't know nothing about. But ultimately, I think that it's so much more, there are so many levels to it, that to really just kind of summarize it into a list of barriers that we've seen would be unfair. And it would be truly unfair to our efforts collectively and to our communities as a whole.
Definitely. Thank you so much for that.
If I could
Yeah.
comment, is this being recorded, by the way? Because I still need a job, so I just want to know.
It's recorded.
I think it is. I see it.
It is.
Being
I see
recorded.
the dot right there. It is being recorded.
So I will refrain a little bit, but what Dr. Soto just said is 100% right. You know, I've only had one job in my whole career, and that's at Jamaica Hospital and the clinics we serve. So there is inequities in the healthcare system. There's inequities who got COVID, because the people who got COVID lived in apartment buildings, rode on buses, went into trains, went into nursing homes to take care of patients. So that's why we had an epidemic in nursing homes. And that's why people don't want to get vaccines, because there is a distrust for the healthcare system. And those that provide healthcare in this system, whether it's language barriers or other cultural barriers, realize that they're real. It's not something that someone made up. Like, many people are scared to get vaccines, and many of them have reasons to be scared to get vaccines. And much of what happened during the pandemic just highlights what's wrong with our healthcare system in general over the last probably 75 years of healthcare. So I'll have to refrain from the real things I might want to say, because like I said, I still need a job. But the reason the vaccine distribution didn't go right was realistically, and I'll make it simple so I don't get in trouble, a state versus city problem, and who would look better in giving the most vaccines to the most people in the quickest fashion.
And to touch on that, I also want to say that things that were a solution to a barrier can turn into something that is the barrier itself. In the beginning, we had an issue, like I said, with people living in the city, people like NYCHA. Those have now become, now that other people are getting their vaccines elsewhere, those are becoming limitations. So I had a case, like I think it was last week, where, first of all, these things were happening all throughout the weekends when we started this vaccination referral system within the T2 CBOs. Many of them were set aside and figured out. But last week we had someone in Staten Island go up to one of the CBOs, called us. One of their community members had approached a vaccination pod site, and they were turned away because they didn't have proof of residency. So you're dealing with something that was put in place to reserve vaccinations for people in our community, but now we also have people that are undocumented, which was the case here. I reached out, I just blasted like 15 people at different organizations or different departments within the vaccine efforts, and said this should not still be happening. And the answer was at the time, well, it's okay if the permanent, the lease signer has a letter that they handwrite even on behalf of the person that's subletting from them. That doesn't even begin to address the number of people that are in NYCHA developments but not on the lease or receiving email or receiving mail at those locations. So now we're working to remove that, right? Remove that barrier. Another thing is age. And speaking of for the task force on racial inclusion and equity, those tree zips, we didn't start out with that. That came a couple of weeks after we had started doing the vaccination referrals at the CBO level. Once that happened, we now suddenly have CBOs who are not necessarily working within those tree zips and don't have a huge community base in those zips, but with plenty of marginalized community members that need to get the vaccine. So when we're telling them to go out and reach and call people, they're also having to meet them with the response, oh, you don't live in this zip code. I can't schedule for you, but you can still go online, which at the time we were speaking with 65 and older, and fight everyone else on a technical platform that you may not understand. So, and that, those two things are because you just live across the street, right? A lot of the work is tied to numbers, and one of the most convenient pieces of that are numbers that are tied to neighborhoods through zip codes. So I could be on one side of the street and my neighbor's getting vaccinated and I'm not able to get vaccinated. And now I'm going to a community-based organization whom I trust, and they're telling me, I can't do anything for you, sorry. So it's, I say that because a lot of my work is now lobbying and advocating on behalf of the community-based organizations who are at a really difficult middle ground, and that's part of the trust. when pods were moving from location to location, you had these elderly people that were not able to access phone. They didn't trust robocalls. They don't have emails. And vaccination sites were changing from one week to the next. So they were showing up at these locations and no one was there. So now we're jeopardizing trust in the entire system, as well as the trust that we've built with the CBOs and the trust the CBOs have with their community members. So it's just, and that puts a lot of strain on the system. And now one more thing, we are having walk-ups, sure, but week before last, I want to say, I can't quite, every day is like 3 weeks in this project, as everyone else I'm sure knows. But I believe like 90% of vaccines were unused, or somewhere a really, really large percentage. It was for sure 60% a week or two ago. Now we're at an even higher rate of vaccines that are not being used. So the barriers are changing. We have to figure out a way to meet people on their grounds and in their normal movement to get
I
those
think,
vaccine rates up.
yeah, I think that kind of leads into one of our next questions is how are you preventing the vaccines from going to waste, basically? Like what are some strategies, or have you figured out how to do that now that you see that is a rising problem? Because of I hear in the discussion that yes, we have walk-ins, but we also still have that aspect of the digital divide of people still trying to get appointments, especially if you don't fall in the category of being 65 years and older. So what are some of the things that's being done now to kind of address preventing waste of vaccines that we have available?
I do want to just, Keosha, just to maybe waste is one thing, and then maybe having too much vaccine without maybe a place to put it is different, because the vaccines will not go to waste. I mean, waste is like, let's say we have a vial that's open and we don't
Hmm.
have an arm to put the vaccine. So I don't want to give people the impression that there's like this waste of vaccine happening, if that's okay.
No, thanks for clearing that up for
Of course.
everyone. So they,
Yep.
again, this is a educational part for all of us to kind of like learn
Yeah.
what's really going on. So
But
thank you.
no, of course, and I appreciate you allowing me the space to do that. But the one thing that I think is where we're at now, and we planned for this, is that where we have more vaccine than demand. But I think that one thing, and we still have to do a lot more work in assuring that this vaccine gets into people's arms for sure. And I think this is really a perfect forum to get ideas from the students here and all of my peers. But I think one important thing that we keep hearing over and over again is that our community members, especially our older adults, they trust their primary care physicians. And then of course, there's still a portion of the underserved, the undocumented, that do not have primary care access. But for the larger portion that does, or the portion that does, they trust their primary care physician. One of the ways that we are trying to reduce the barriers is, one, consolidate. So rather than having pop-up locations all over the place that are maybe not filling up the appointments, and now we have perhaps too many places, and going back to the infrastructure that we know, which is big box pharmacies is another place. So primary care physicians being the primary place that people trust in terms of receiving a vaccine, any vaccine, and then big box pharmacies. So now that we have more vaccine available to us, how do we now distribute this vaccine to all of the access points that we are familiar with, and now drive in individuals to those locations? That's still a barrier because we need to be able to identify what that method will be. The other is maybe consolidate what we have now that is very, very spread out. And like Blake mentioned, is meeting people where they're at. I know with the flu vaccine, J&J makes it more feasible to do that, is being able to go to food pantries. And if it's 50 vaccines that we administer, then it's 50 vaccines. If it's 25, it's 25, but no longer having to use like the big like almost like big, well, one, we didn't have it. We didn't have a refrigeration for Pfizer, but let's say Moderna, that's a little bit more portable than Pfizer, not having to rely on like a vial of 10 or a bigger set of vaccines because of the way it was packaged, and now having something more portable like the Johnson and Johnson that would facilitate that point of access of meeting our community members where they're at
Is that
as
one
one
of
option.
yeah, is that one of the major differences is I know like how they were made is different, but between the three vaccines that we have available, but actually being the, you know, if how portable the and the storage requirements for the each of the different vaccine has that is that one of the major differences between the different versions um
Yep.
and also the age availability. I know like Pfizer's available for those who are 16 and up. And so can you, what are the major differences between the vaccines and how has that affected the distribution besides the storage? Is there anything else that we should know?
So if I could make a couple of comments. So one for the three colleagues from the Department of Health, Blake and Angela and Jamie,
It's Jaime.
thank Jaime, I'm sorry,
Yes.
like your comments are amazing and enlightening to me. So, like I said, I spend 50% of my time as an administrator at Jamaica Hospital and 50% of my time as a primary care physician in Kew Gardens, which is actually not an underserved zip code, but most of my patients are underserved. And I'm one of the primary care docs that said, I'm not taking the vaccine. And the reason I didn't take the vaccine is I had to sign a piece of paper that said, one, if I take the vaccine, if I waste it, if I give it to the wrong group, is the second thing. That I am liable to a fine from the New York City Department of Health for $100,000, sanctions against my medical license and or criminal charges. So that's why I don't take it there. And I run the pod for Jamaica Hospital, so I see the other end. So I look at both ends. And we've created a system of fear from the beginning of COVID, whether it was nursing home patients or vaccinations or where to get tested. And it's all the same. So, testing, tracing, vaccination, who's getting sick in what communities, it's all the same. We've messed it up, and it kind of has to be a do-over. And we kind of have to educate the community about the fact that it's more important just to get a shot. It doesn't matter what the shot is, because if you get the shot, you're more likely to live than if you don't get the shot. You're more likely to get COVID and still die. And people are still getting COVID and dying because of the distrust of the healthcare system that's been created 100 years ago, but is continuing now. And there's a reason the distrust continues, because I don't trust it. So if I can't trust it and sign forms, why should my patients? So that's where we're at now.
Definitely. Thank you, Dr. Roth. And you're speaking to some of the issues related to the messaging and how valuable and important it is for individuals to get vaccinated. But also, I think what we want to kind of also address are like, what are some of the side effects of the COVID vaccine, as well as what happens after you get vaccinated? Like, how do we handle getting tested? If you're a vaccinated individual, does the same rules apply? Or are we you, excused from actually getting tested if we are exposed as we, like we were before the vaccines came available. So can someone kind of just explain some of the side effects of the vaccine, and then also talk about what happens after you get vaccinated? Like, how do we deal with testing? Because now we have most of the people here who are attendees, they are now available, they eligible to get vaccinated. And so these are questions that they didn't have to ask before, but now this is a concern for them also now. So can someone just chime in about those things? Maybe start with the side effects and then we go into testing issues.
Dr. Roth, do you want to take this one?
I'd be happy to. I don't want to hog the audience, but so the side effects of the vaccine are the same side effects of COVID, unfortunately. and some of them are real and significant, including blood clots and death. But there is no doubt that the safety of the vaccine and getting the vaccine, the benefits far outweigh the risk of getting it. And I could tell you from personal experience, I got COVID. COVID almost killed me. I'm a long hauler COVID person. Uh, the evidence on long hauler COVID and the vaccine is unclear, but we need to educate people that you need to get the vaccine, that the vaccine compared to getting COVID is a million times safer. And unfortunately, yes, you may get a lot of side effects, but your chances of dying are much less. And the second question is, how do you handle yourself after you get the vaccine? It really shouldn't change, because what we do know, and I've seen this in my own clinical practice, is one, people who have gotten COVID or are now getting COVID a second time. People who have been semi-vaccinated, like one vaccine or even had two, are getting COVID again. People who get it the second time or have been vaccinated, it's much milder, but that's what's creating part of the additional problem. Is we're now creating asymptomatic carriers in people that are either got COVID the second time or have gotten the vaccine. But I still push that it's better of all of those things to get the vaccine, because you're going to live, than not get the vaccine and possibly die from it.
Definitely. And Angela, did you want to chime in on that?
Yeah, maybe just give a little bit of kind of uh, what we are kind of seeing. One, there's a public site called VAERS. It's public. Everyone who gets a vaccine is encouraged to participate in something called Be Safe. And people are monitored initially daily. You provide your symptoms and they give you a list of multiple choice symptoms, and including information about whether you actually sought medical care. That information is reviewed daily or hourly by a whole team of either NIH, CDC, and other independent entities that are actively looking, which is actually what identified the 6 people with the Johnson & Johnson that developed that pause. And just to differentiate a little bit, in terms of the blood clots, that was something with Johnson & Johnson. We have not seen anything with the mRNA technologies, which is the Pfizer and the Moderna. I think that's important to highlight. The other is the expected reactions are very similar to the reactions that anyone would get with any vaccine. I do agree with Dr. Roth that some of them may mirror some of the symptoms for some of the people may mirror very similar to a COVID-19 infection. TMI, but I actually was infected with COVID-19 and I was able to get the Moderna vaccine. And there was a moment for my second shot, especially, not so much the first one. The first one felt like a tetanus shot. If you've ever had a tetanus shot, that's exactly how it felt. But for the second one, there was a moment where I was like, that headache that I remember distinctly for a COVID-19 infection, that the chills, but it was short-lived. It was 12 hours. I took some Tylenol, it was gone. When I was sick with the COVID-19, however, I could not get rid of that headache no matter how much Tylenol I took. Now that was me, and that's a little bit TMI, but I think it's also important to note that, like Dr. Roth said, it doesn't compare to an actual infection. And that is always important to just share with the general public as well. So for those of us in this room that have not been vaccinated, that's some of the things to expect, but not everyone will feel it the same. But it would be headaches, perhaps mild, all of them mild, chills, perhaps a light fever, body aches, but nothing that should last more than, I think it's 48 hours. If it lasts longer than that, which we don't expect, please seek medical attention and reach out to your primary care physician.
Thank you so much. We're going to continue with our program and kind of get to some of
the vaccine tomorrow, so I'm really
Yay.
excited to go through all of this.
You're getting your second shot, you said?
Man.
Yes, great. Congrats on that. And and I always tell my students, if you have any questions, I've been vaccinated, and so I'm always open to answer any questions regarding my experience being vaccinated. Um, so we're going to move on to the next part of our agenda and kind of talk about some of the vaccine myths that we've been hearing about. And maybe panelists can kind of address them and let us know, like, yes and no to some of these myths. And so one of the first one that I constantly hear now is, if I've already had COVID-19, I don't need a vaccine. Um, how, what's the answer to that?
I'd be happy to answer. So all the 6 myths there are all myths.
Yes.
And again, no one knows, unfortunately, this is a new disease, how long your immunity will last. And that includes whether you've had a blood test, because even from the blood test, if your blood test shows immunity or doesn't, we really don't know if you could be reinfected again. But we need to stress to people that it is by far and away better to get a vaccine, get some side effects. So I am actually seeing now the most common visit in my primary care practice is side effects of the COVID vaccine. And each person I tell, I am so happy I'm seeing you for this today, because you're not dead. You didn't die from COVID, and you're going to live a long life. So I'm glad you're getting better. I'm sad that you've had a few mild side effects, but thank you. You're going to help save the world, the population, and most importantly, yourself and your family.
One of the things I think about the myths is that I think we rely on our social networks and the people around us to kind of build trust within anything. I mean, that could be from hair products into food choices. And I think it also relies, we can see that relationship with the vaccine itself. So how can someone who is not a professional, like everyone here is on this panel, actually debunk some of these myths with the people within their social network? Like, what are some things that we should tell them about the vaccine that will help us to build trust within the people within our social network?
I'm sorry, I keep talking.
It's okay. That's what you're here for.
Yeah. One of my favorite ones, Keosha, is the vaccines were rushed, so they can't be trusted. I always love to give kind of a quick glimpse of the history of SARS. And one, we know it already. We know SARS, that happened almost 20 years ago, or MERS, I forget which one, MERS or SARS, but nevertheless, that's been a 20-year kind of in the making, if you will. Not SARS-CoV-2, but it's information that we've had. So coronaviruses have been researched for decades. Even though this virus is new, a lot of the information was not necessarily foreign to our researchers, our scientists. And the other is that it's really easy to lose sight of where we are, right? So we think New York City, but ultimately this is global. And one of the things that there are some silver linings, and one silver lining in this entire thing is the world coming together and collaborating and really sharing this information. I mean, if we think about it, on January 11th, China shared the entire genome structure of this virus. January 11th. And by February, we had many, many entities such as Pfizer and Moderna, the companies that have made these vaccines, already on the ready with federal government money to basically begin the production and the research around this vaccine. So this is a global collaboration in the sharing of information, and also in almost in parallel having clinical trials that are happening in the sharing of information yet again. The fact that we have public access to the many symptoms, of course, de-identified, but even at our CDC website, of all of the symptoms and reactions that we're getting, I mean, that's also telling of something in this effort to be as transparent as possible. But just coming back to kind of the history of this virus, people have been studying coronaviruses for decades. The technology of mRNA is not unknown. It's been tried on as treatments or form part of treatments for cancer. We also are building off of the research we've done around Zika vaccines, around Ebola vaccines, including HIV vaccines, right? So all of this is information that we're building off of. And I don't know if anyone else wants to share, but this is not something that is completely unknown to us.
Definitely.
I'll just support and say you're 100% correct in all of your comments. So thank you. That was great.
Yes, that was a great overview for everything, addressing some of the concerns related to the vaccine and how it's created. And most importantly, I think the takeaway message from that is to trust the science behind it, really. And that people have been working together, hasn't been a one team just doing this. And so these efforts are actually been measured and been researched for years, and we're just applying our knowledge to this new issue now. So thank you again for that overview. We can continue to the next set of myths, I think, to the next slide. Okay, so one of the things also is that the vaccine can affect women differently than men, um, or can affect, I'm sorry, women's fertility. Um, how has that been addressed in the messaging, or what are some things that have been said to address those concerns?
I actually just heard about this yesterday. I don't know if it's because I've been under a rock or just so busy with the day-to-day operations, but one of my someone I actually work with on the team mentioned this one about women who had the vaccine not being able to conceive, and uh, the suggestion actually came from her primary care physician, which kind of blew me away. I know that we're still in the beginning of all of this, but it's yeah, just adding to the story. I don't really have an answer to it, but
Yeah.
So the vaccine was created using proven technology. The myths are all myths. And,
Mhm.
the only thing we could say is you can still get the virus, you could still be contagious, and you need to continue all the safeguards of social distancing, wear a mask, protect yourself. But there's no evidence to any of the other things associated with the vaccine, except the fact that women do seem to be more prone to getting hypercoagulable states associated with the vaccine. So that is true, but women in general are more prone to hypercoagulable states in general. So we see that in disease states as well.
So one of the myths that's come out may be a little bit confusing for some people, because we have received new recommendations from the CDC recently regarding those who are vaccinated and how they can wear masks and how they can't wear masks. So there apparently from the CDC, there's been recommendation that those who have been fully vaccinated can go outside without a mask. And so uh, how, what does that mean? Like, what are the other recommendations, and how does that fall in line with people who've been vaccinated? And also, how does that address individuals who live in households where some people are vaccinated versus others not being vaccinated? Like, what are some things they can continue to do um, as it relates to that?
So I'd be happy to answer again.
Mhm.
The vaccine really doesn't change anything. So in my opinion, being outside alone, you never needed a mask. If you're in a crowd of people, whether you're vaccinated or unvaccinated, outside and close to people for a long period of time, you need a mask. But if you're going for a walk in the street, like I take my mask off when I leave the hospital and walk to the parking lot and drive home. But if you're home with people you know, you're home with people you know. If you're with people you don't know, and regardless of the vaccination status, you should be social distancing and wearing a mask, because we know that the vaccine will prevent symptomatic disease, but does not, and prevents bad disease, but does not necessarily prevent asymptomatic carriers.
Thank you. Thank you again. So everyone here, that if you get vaccinated, you still have to follow the protocols related to social distancing and wearing masks in crowded areas to stay safe for everyone. Any other comments from the panel?
Yeah, just on the mask piece, just because it's coming from the CDC, you know, public health is based on population level data. So this is an aggregate of all of the environments and communities from wherever they're collecting that information from. So just because it's something that's coming from the CDC doesn't necessarily mean that it works within the context of New York City and that it's automatically best practice. I think you'll see a little bit of hesitation on the part of the Department of Health for just really jumping on everything that's being mentioned around the loosened face masks policy.
Thank you. Definitely. So more updates regarding best practices. You should check out the New York City Department of Mental Health and Hygiene's website to find out what New York City is actually doing as it relates to the vaccine and also other social practices for prevention of COVID-19. And now we're going to go to the last part of our agenda, which is opening up to questions from the attendees. I know I had some questions that I just want to go back to that some people had mentioned earlier. One was to kind of define what a CBO is and what was the importance of funding it, as mentioned before, in regards to addressing in parts of the response to the COVID-19 pandemic.
Yeah, I'll take that. So the community-based, so a CBO is a community-based organization. That's pretty much the acronym. What was new this time that wasn't new before was that there was in the past, it was written in the public charter that community-based organizations could not get paid for work, could not modify their contracts for work performed during some kind of emergency response. And so there have been many advocates for the last decade, I would say, especially post Hurricane Sandy, that have asked that charge itself get modified. And so we were finally able to provide community-based organizations with some funding, and also allowed them to change some of their deliverables for whatever contracts already existed to deliver on whatever public health needs needed to be delivered to help us fight back, essentially.
Thank you. My next question is related again to the vaccine. Do we currently have any understanding of how the vaccine may affect the capability of those that are vaccinated in spreading the virus to others? And, do we have any?
I'd be happy to answer
Yes.
that. So I think, unfortunately, in a negative correlation, people who have been vaccinated can unfortunately be asymptomatic carriers, give people a false sense of security that they got vaccinated and they're fine, go to a crowd of healthy people, be a carrier, and give them the disease. So we can't let our guard down. Everyone should get vaccinated, but everyone should continue social distancing and wearing a mask and washing your hands and doing the right things every day. Because if we don't, we could increase the transmission. So I had it, unfortunately, a week ago. One of my patients was a school teacher, totally protected, vaccinated, came home as a carrier to her mom, who was 80 years old and brought COVID home to her mom and gave it to her. She was fine. Mom got COVID, who didn't leave the house. How did she get it? She got it from her vaccinated daughter, who was an asymptomatic carrier. So we know this is the case. So people should get vaccinated and they should continue to social distance, wash their hands, and wear a mask.
Thank you. Thank you for that message. Um, the next question is, could you please highlight some of the specific approaches that your organizations took to address vaccine-related fears, specifically in communities of color? Can anybody kind of like elaborate a little bit on that?
Yeah, so we have, well, right now, we're in the month of Ramadan. I talked a little bit earlier about zip codes being priority zips, but we've seen cases where in one day there may be 16 cases in one building. And that seems to be related to breaking fast at the end of the day. So utilizing the community. So India Home is one that are able to reach and really get into those communities. Another is going through gatekeepers of the community. So not only do we work with FBO leaders in the Department of Health, but our organizations, National Black Leadership Commission on Health, plug in for them. If any of you are wanting to go to, or obviously wanting to go to med school, they have an excellent apprenticeship sort of thing. But working with the community gatekeepers and speaking the language that the people that are local speak.
Definitely, yeah.
Oh, sorry, Keosha, go
No,
ahead.
no, I was just nodding verbally. You can continue.
Absolutely. Some of the things that we've also done is we host community conversations weekly, multiple times a day, and it's very informal. In the many multiple languages that represent in New York City, certainly the top 13. And more recently, since the beginning of, where are we at now? 1 month. I think I speak what Blake is saying. It just becomes weeks. We're in April. We started probably at the end of February. Um, Also hosting community presentations in indigenous languages. So it's Spanish and the indigenous languages. Uh, with the understanding, and this was also based on community feedback, that there are many indigenous languages. Not everyone that is from the Latin Americas or Caribbean speaking, Spanish speaking countries speak Spanish. Really understanding, at least for me, a learning experience of how many people speak the indigenous languages that are here and not necessarily Spanish as a first language, even though we assume that because they came from Latin America, they are going to speak Spanish, then that is not the case. So really being more conscientious on that front, and making sure that we no longer start a community conversation in English, that we started in the language that people feel most comfortable. And it really does change the dynamic even in the room. So having to go from an English to Spanish even, and I'm sure that a Spanish to now an indigenous language. So ideally, our goal would be to deliver the community conversation strictly in the language that is most comfortable for the people in the room. Virtually in this case, but ultimately as we move forward, and I do believe we will get there, in-person presentations in the language that people feel most comfortable. And the other part is really working with liaisons. So Jaime as a liaison, but also a liaison that are representative of the communities. I work directly with my colleague Elisa Mazur, who's a liaison to the Orthodox Jewish community, and really making sure that there's a term that I've learned from the LGBTQ TGNC community is nothing without a, and I'm messing it up, so please correct me if you can. Nothing for us without us, and I just messed it up, and I'm really
You
bad
got it. Nothing for us without us.
yeah,
Nothing sounds like I got you. I
yeah.
understand.
So making sure that we have representation that looks like the community, that is delivering the services, that is, yeah, basically everything, right? And I think that is one way that we're beginning very slowly to change even the structural, it doesn't touch on structural racism, but ultimately having representation of everyone in the room, not just one single ethnicity, not just one single gender or sexual orientation, but basically having as many people in the room as possible.
And getting rid of that idea that is one size fit all for everyone in our community, especially which is very important in a diverse community like New York City to realize that. And I'm happy to hear of the efforts that the Department of Health is making to engage the community members and the residents of New York City. So thank you again for that.
Yeah, so to the point you just made, but to also have, and for us to have foresight in the future, to have things like this where we can communicate to people in multiple languages very quickly and have things that are able to get stood up very quickly, because we have learned from many emergencies that communications will always be a need. And if we have a cadre of people who we can activate as they do us at the health department, and activation means you get pulled from your regular job to do just this, right?
Mhm.
To help communicate a message, that would be foreseeing. That would be the kind of foresight that would help us get ahead of any future emergencies.
Thank you. And I think our next and close to final questions is addressing some of the comorbidities of people, and especially we heard that they're make people more susceptible to COVID, and stressing the importance of masking up and getting vaccinated are important messages to convey to people, but also informing people the importance of prevention as it relates to lowering your blood pressure and reducing your risk to diabetes. Is New York City Department of Health planning to do more to address messaging regarding comorbidities in relation to COVID-19 and the vaccine process, and just in general, because there's so much related to just getting vaccinated and get testing, but how about overall health, how that contributes and to people's susceptibility to COVID-19, like what kind of messaging is being done related to that?
At least with my team, I've asked leadership about this. There are a lot of grants and everything going around about what we're doing right now. That next step about being healthy and entering the workforce, not just physically, but emotionally and socially as well. And what I'm seeing is that, and I could be totally wrong, but what I'm seeing is that we haven't really gotten to that point yet. That the focus is still so really nearsighted in that respect.
Yes, we seeing it, and I'm on the test and tracing messaging work group, and these are issues that we constantly bring up of how we can convey messages to different people, and how we can kind of translate this into how to be healthier individuals with COVID-19. So that can kind of minimize some of the fears, but bring up the concerns at the same time. So I think it's a complicated question and issue that because we're putting out so many fires, I feel, at the same time. And so there's a lot of efforts going on, but I think they would get there. I trust that especially with this great panel and the people on the panel, that we would definitely get there. Jaime, did you want to add anything, or did you?
You saw it in my face.
Yes, I saw it in your face. I did. I did.
Yeah, no,
I read faces.
we started just a little plug for the Harlem Action Center. One thing that we started just recently is what we call the Resource Navigation Desk. And so the idea here is to start plugging people into services that are non-COVID related, that are in our catchment areas, with things that they might find useful in the weeks and months coming forward. Right. So the question really is like, what zip code do you live in? If you live in these zip codes, what's of these services, which would you like to have us refer you to? And it's everything from group fitness classes to cooking and nutrition classes to lowering cholesterol classes to managing diabetes classes. Like we start getting back to this normal that's unfortunately is our old normal, but it at least feels like there are and will be opportunities moving forward as this kind of mass vaccination effort continues to start thinking through ways of plugging people into services to help them on a daily kind of non-COVID related life issue.
Thank you. That sounds like a great initiative that's happening with the Harlem Action Center. I think that's the end of
I'd
our
like to add
panel.
one
You wanted
comment.
you can
Yeah,
add a comment.
so for all the to-be doctors in the group, we're not that important. So, health has very little to do with the medical care we give. Health has everything to do with the education that we give about healthy diet, nutrition, well-being, mindfulness, an integrative approach, and prevention. And the data clearly shows that medical interventions only affect about 20% of longevity in life, and that 80% of a longevity is really the social determinants of health. And that's what we need to invest in. So I know many of the young people are going to be, physicians. And as my physician hat that I wear half my time, I make much less impact than when we address the social determinants of health and the screwed up healthcare system that we have.
I think my U1 students who are in my introduction to population health already know that statistics, so they're pretty prepared already. And anyone else who's
It's
taking
real.
the
I'd be
course,
happy to give you
yes.
talks. I have multiple lectures on that topic.
I know. But again, I really want to thank everybody on the panel for coming and taking the time out your busy days and schedule, and with all the work that you've been doing to support the community as it relates to COVID-19 and our overall health and wellness in New York City. So thank you again for joining us on behalf of the Physicians for Human Rights. We appreciate this time. And I also want to thank the attendees for coming and participating. I hope that I know I learned a lot and I got a lot of information, a wealth of knowledge. And one message that I want to tell you is to make sure everything that you learn here today, share it with your community, share it with the people in your household, your family, your friends. And that is really one way that we can address some of the fears and myths that we've been hearing in our community, is to address it with facts, really, and that it's in from a trusted person, and you are that trusted person. So consider yourself a messenger and an advocate for health in this.
And please share any of the comments that weren't able to get to. This all feeds into the same belly. So you would at least have people communicating on your behalf. Um, uh, so it'd be very, very, really useful if we could get a copy of the chat box.
No problem. And if anybody want to just add reflections, I know I'm taking over now. I do this in my class at the end. If you want to add a reflection of your experience here, share it in any comments or questions that you felt that you still have. Just put it in the chat box before the end of this event, and we would gladly share it with you, Mr. Gutierrez, so you can kind of elevate it to to everyone there at the Department of Health. Again, thank y'all so much for coming and sharing your knowledge. And thank you again for all the work that you've been doing for the past year and a half. We appreciate you and we value your service to this community. And I can turn it back over to our great students who are leaders of the Physician for Human Rights. And so they can find words if they want to say something.
Thank you, everyone. That was a beautiful note to end on. Thank you for coming and personally taking your time to attend. Thank you, Dr. Bond, for making this event happen and for facilitating. We really appreciate you. Thank you, Dr. Roth, Mr. Fountain, Mr. Gutierrez, and Ms. Soto for agreeing to speak for our event. We appreciate all of your support and insight. Today's event was very helpful and successful, and we learned a lot. Thank you, Dean Macbeth and Dr. Koiko, for being here and for your support also. We wouldn't have gotten to this much participants without you all. I also want to give a special shout out to Sebastian. He's the former president of PHR. Thank you, Sebastian, for being here and supporting us today. Are you here?
Yeah, I'm here. Thank you for the shout out. You guys really didn't have to. This was an incredible panel and a really important discussion. So thank you to all the panelists for joining us. And I also want to say that I'm really, really proud of the M1s and the undergrads for putting this together and for being really, really active and doing such great events. So really proud of you guys, and excited to see where you guys are going to take Physicians for Human Rights at CUNY in the future.
Thank you so much, Sebastian. Thank you, everyone. We hope you have a great rest of the evening and get vaccinated.
Yes, we have a vaccination site at CCNY, so check it out.
Right, there is a
Take advantage of it in your
Jamaica
community.
Hospital has a ton of vaccines if anyone wants to, so we're good.
Thank you, everyone, for coming.
Everyone, have a good night.
Thank you, everyone. Thank you, Keosha. Thank you.
Thank you, everyone.
you.
Have a good evening.